Hi, everyone. Welcome back to Voices of Dental AI, where we explore the intersection of technology, dentistry, and the human experience behind innovation. I'm your host, Loren King, Chief Evangelist at Trust AI, and today I'm joined by someone who truly embodies what it means to live at the cutting edge of dentistry and technology. I have Dr. John Flucke, who is a clinician, he's a writer, he's a speaker, and he's a true technology evangelist. So we have two evangelists on this podcast today. This should be a lot of fun. He's spent years bridging innovation and patient care from hands-on clinical dentistry in his Missouri practice, right?
Right?
And then to his work as chief dental editor and technology editor for Dental Products Report. He's also the mind behind one of the most read dental blogs online, which is called Ramblings of Dentistry's Technology Evangelist, which has reached over 3 million views, which is insane. So, Dr. Fluke, welcome to Voices of Dental AI. I'm so excited to have you.
Thank you, Lauren. It's great to be here. We have like evangelist squared today, so we'll see where it goes. Should be some high energy.
It should, absolutely. I'm sure we could probably make this into a series at this point.
Well, we kind of already have because for people that don't know, I have a podcast, a Technology Evangelist podcast, and Lauren was a recent guest, and that one will be out before too awful long.
All right, let's dive in. So, you've seen dentistry evolve more than most, I would say, correct? Okay. So, you've seen early digital systems to AI and advanced diagnostics, all the things, all of the ways that we've evolved over the years and the decades. But I want you to take us back to where your passion for technology began. So, what was that moment where you realized innovation is it, right? It's going to shape the future of patient
Sure.
care.
I really like to say that I was born right on time. I was born, in an analog world, and in dentistry, I grew up in an analog world. Everything was paper. And in the early 90s, I bought a computer, one computer, and I was going to use it to do accounting in my practice. There was uh, an opportunity back then. There were a lot of DOS-based programs that were designed for dentistry, and it basically did your accounting. It's kind of a funny story, actually. I bought it, and the company, I bought the software and the hardware from the same company because I wanted it all to work together. And they sent it to me, and one of the things was that you could, connect it to your phone line so you could fax with it, which was really cutting edge. And I called the company when I opened the box, and I was like, I don't have a modem. And they were like, oh, they're built into the computer now. And I was like,
What?
oh my gosh. So anyway, that's how long ago it was. And I started out with the computer, and then I went to an intraoral camera, and then we got digital radiography, but it was all standalone stuff. And if you wanted to take an x-ray, you wheeled this cart with a different computer that connected to your sensor. And then in the late 1990s, very early 2000s, I had upgraded to a Windows practice management system called EagleSoft. And EagleSoft had actually purchased the DOS program that I was using. And I had begun tinkering then. I was kind of a hacker. I would like modify hardware and software to do what I wanted.
Why does that
And
not surprise me at all?
so EagleSoft called me, and they were like, hey, we think there might be a chance to actually put computers in the operatory, maybe, to do like your charting on the computer. What do you think of that? And I was like, I think that's genius. And so they flew me out to their headquarters, which is in Effingham, Illinois, which is a little tiny farm town. But anyway, and I helped them design the chart. And I was running it. I went back to my office and I bought a laptop, which was, I think, like $7,000 or something back then. And I would carry the laptop around with me and move from room to room and do the charting and the stuff. And I was like, this is going to be huge.
Yeah.
And so probably late 90s, when I didn't have to really like hack it anymore to make it do what I wanted, that's really when I saw where this was going to go.
That's incredible. So you've literally seen from the start of it, essentially, and how expensive it used to be. My God, did you say a laptop was $7,000?
Yeah. Yeah. In fact, one of my first lectures, it's kind of funny because the ADA kind of saw this coming too. And I was just a kid, practice in dentistry. And I got a call from the ADA and they said, hey, in addition to our ADA meeting, we're going to add one day at the beginning of the meeting. We're going to call it Technology Day. And would you come out and talk? And so that was one of the first lectures I ever did. And most people at that meeting were carrying big slide carousels around with them. And I showed up with a laptop and an external hard drive. But one of the things I remembered is they had, like this little kind of a mini exhibit hall of this is the future. And I remember Intel was showing a 12-inch LCD monitor and it was $21,000.
Oh my
Yeah.
gosh.
It was the first flat screen, not in a laptop, that I'd ever seen in my life. And it was just stupid expensive.
Oh my gosh.
And might I add that the laptop that I used then that I spent like $7,000 on had 24 megabytes of RAM. And that's because I went for the high end package.
My gosh.
Yeah. I mean, seriously,
This
it
is
is just
insane.
crazy. Yeah.
This is insane to me. Okay.
Yeah.
So, knowing all of that and
Yeah.
knowing everything that you've seen, how have you seen technology change how do I ask this? How do you see how technology has changed the approach we have to like diagnostics and treatment planning?
Well, okay. So getting in the Wayback Machine again. So we had these unconnected systems, cameras and x-rays. And then, we finally came along with, let's put a computer in the op. And so we had we had this innovation 1.0 is what I call it. And that was when we had the cameras and the x-rays and they were all separate. And then we put the computer into the operatory. And suddenly those systems, the computer in the op became like the hub of a wheel. And then these other things were like spokes that connected to it. So initially 1.0, and then what I call integration 1.0, which is when the computer would connect to these things. And that went along for a while. And then in the late aughts, around like 2007, 2008, we started to see things like the Trios and the Itero and these digital impression systems that you could actually use and send things to the lab. We'd never had that before. We had CEREC and a system called E4D that were these combined CAD-CAM things, but you had to do it all in office. And so we got these 3D systems that would allow you to send things to the lab. And then cone beam came along and we started to move really into 3D. And that started what I call innovation 2.0.
Okay.
And the bad thing about that was it's like things splintered again because you had the operatory computer that you could use for some things, but then you had a cone beam and you had digital impression systems and all these, and those were once again standalone pieces. And then in 2015, I think was the first time I'd ever seen artificial intelligence used in radiographs. And it's really interesting because I remember I had a meeting with these two guys who were tinkerers. They were computer engineers from India. And we had a super secret meeting in Chicago where we were in a room by ourselves. I had to sign all kinds of non-disclosures and nobody knew what was going on because this was brand new. And I was like, oh my gosh, this is absolutely amazing. And then AI started to creep into other things. And then in 2023, GPT came along it went live in February of 2023. And then suddenly you couldn't look at a newspaper. You couldn't, read a website without seeing artificial intelligence. And so I think what we're just teetering on the edge of right now is that we're about to enter integration 2.0. And everything is going to come back together. And what I'm really excited about with that is that you'll be able to merge your intraoral scanner and your cone beam. You'll take, a new patient will come in and you'll take a cone beam. And then as part of the intake process, the hygienist will take the intraoral scanner and they'll scan both arches. And then in the background with no intervention, that AI system is going to find the common data points, put that scan into the cone beam DICOM volume, and you'll have a continuously updating 3D patient. These systems are going to chart for us. They're going to at least give us rudimentary perio probing that we can then check against rather than having to do it all and make rock solid sure of everything. It's going to help us with diagnosis. It's going to help us with our treatment planning. If you need a crown and you've got the ability to either 3D print that crown or you have a mill and you can mill that crown, the artificial intelligence is going to say, hey, I noticed you took a scan of a crown prep. What do you think of this crown? Because I've already designed it for you and you can edit it or you can just make it. And so it's going to take all of this stuff that is, like pieces of broken glass and put it together into a coffee cup. And then we'll be able to sip coffee and talk to our patients and interact with our patients and develop better relationships with our patients while the machines do the stuff that we're doing now. So that's where I see it all going.
I love that. And I very much agree with you 100%. But my question to you specifically is, especially knowing everything that you've experienced and I guess how your brain works, knowing you personally now, how do you think we're going to balance all of this and still maintain patient like trust and, the human part of it?
Well, coming back from where I am, I can remember actually taking a number 2 bite wing film and flipping the patient track light around and holding that little thing up to this, up to the back of the track light, try not to burn myself, number 1, and taking like a sharp pencil or something and pointing and go, can you see that little black triangle there? And people will go, uh-huh. And I'd say, well, that's decay. And so we need to do a filling, or that's why you need a filling or whatever. And then when we got sensors and we started putting those on a monitor that was mounted in the ceiling that we could bring right down to the patient, I would say, see that little black triangle? And then people would be like, yeah, is that bad? Well, what's this big white thing over here? And the education aspect of it got so much better. Now, the first thing I realized is all those years I was holding that film up and saying, see this? And people were, uh-huh. They didn't see jack. They didn't know what
I
they were.
disagreed with you.
Exactly. Because, he's really excited about this, so it must be important. But when you could show them the image, we get between 80 and 85% of what we perceive about our environment through our eyes, and only about 10% through our ears. If you're married, probably less than 10%. Trying to explain things to patients from a point of view of a doctor or a hygienist or a dental assistant who knows a lot about the subject. I think one of the biggest things that we battle is we forget what we know versus what the person sitting there knows. And so when you could show it to them right in front of their face, blown up 30 times, that was great. But now from a trust standpoint with your patients, now I can show them the native bite wing. And then I can pull up a bite wing that's been run through the AI algorithm, and I can say, see that hot pink area? That the AI sees decay there. And there's 2 things on that. Number 1, patients are blown like, you guys are using AI? And it's funny because you don't have to say artificial intelligence anymore. Everybody knows it. And it's like, oh yeah, we use AI. It analyzes the x-rays and it takes a look at things. I always tell people a couple of things on this. Number 1, I like it because it's really easy for you to see. But number 2, I'm a human being. I miss things. And I love having something kind of, I like to say, that's like a little guy sitting on your shoulder. And he's like, did you look really closely between 3 and
Like,
4?
are you sure? I know
Yeah,
you didn't eat breakfast this morning. It doesn't
exactly.
matter if I eat or not. I'm
Yeah,
still going to see it.
right. Well, and from a practitioner's point of view, when a computer looks at something like that and the AI analyzes it, when it's doing that, it doesn't walk into an operatory like I do, where my mind says, okay, I've got 3 hygienists that are all 10 minutes behind. They all need to check. I've got an endo. I've got somebody in my room with a rubber dam on who's pried open like a lion at the circus. And then in another room, I've got somebody that's broken a tooth, that's cutting their tongue, they're in pain or whatever it is. And I walk in, I'm like, there. The machine doesn't feel that. The machine's just like lack of density here. And it makes me better at what I do. It makes me sometimes faster at what I do, but it also communicates for me. And the patients get that. I mean, the machines are objective
Right.
and the machines won't lie. And the thing is, I've over the years had people say, "Oh, you must be planning on a vacation," or
Doc's trying to buy a new Benz.
yeah, yep, absolutely. And got your eye on a Porsche, do you? And it's hard to argue, or it's hard for patients that are, I mean, some folks are just like genetically they're doubters, but it's much harder to doubt somebody's opinion when an objective piece of software says that's a problem.
Yeah,
Yeah,
exactly. And I've used the technology that we currently have, I've used it in front of patients and I tell them, I'm like, "Look, this technology has no skin in the game. It doesn't have a bad morning. It didn't sleep well or not sleep well last night. It doesn't have debt. It doesn't have childhood trauma.
yep,
It doesn't care whether or not this procedure is going to get covered by insurance or anything like that.
right,
It's telling me exactly what needs to be done regardless of any variables. This is what the patient needs at a minimum on
right,
top of that. So at a baseline, this is what we need to do. And then as the clinician and the expert, I will take that from there. Right.
absolutely,
So, and then, but it's so interesting because the last time I did this, the patient was like, yes, that actually makes a lot of sense. But one thing that I've been telling people for when, Isaac is in offices and all of the things are readily available for everyone to use, I was like, just pull Isaac up in front of the patient if they're skeptical and say, I'm going to leave the room. I'd like you to go ahead and ask Isaac anything that you have a concern with, anything you don't feel comfortable asking me about. I
right.
cannot manipulate this conversation in any capacity. So I'll come back when you're done. Right.
Yeah, I love that.
It changes everything.
The other thing that I think is great about that is I have been really lucky and over the years, I've been in a lot of offices and I've watched people work. I've done like some clinical training on different procedures where I actually go into an office and work with the team for a day or two. And so I've seen a lot of communication between all the staff, including the doctor and the patients. And I think it's funny where sometimes, the whole thing about we forget what we know versus what they know. And I've actually seen people talk to a patient and say, well, there's an interproximal area on the mesial of tooth number 3, and it's undermining the marginal ridge. And so what we need to, yeah,
English.
exactly, exactly, and even even from the point of view of just saying, Isaac, explain this to my patient in
In
layman's
layman's
terms.
terms.
Yeah,
Exactly.
yeah.
Yeah.
'Cause I mean, and I'm not making that up. I've actually heard people give, like, a dental lecture to a patient, and they don't know I mean, if you're lucky, patients know what gingivitis is. I mean, seriously, but they don't
Maybe.
know all the other things.
Right.
And, one of the great things I think about Isaac too is because Isaac is trained on dentistry and dental literature that there's so much stuff coming out now. I just did a blog post today on some studies I found on the oral systemic connection. And even being able to say, um, Isaac, explain why periodontal disease contributes to atherosclerotic plaque in the brain. And just let it go and let it explain to them in layman's terms because there's so much of this that, like, even if you're the best practitioner in the world, you can't know all of that information, but
Right.
Isaac does.
Exactly.
It doesn't get distracted.
And it's up to date information. It's not biased. It's not political. It's
Right.
not religious. It's not fluoride is toxic. Like
Yeah,
whatever the trend is at the moment of don't have this in your home, don't ingest this. If
right,
it's not proven, it's not going to pull from it.
right,
And I think that that changes the game, but also it helps so many clinicians become on the same playing field and pulling from the same baseline, whereas not everyone can afford to go get extra CE after their program. The
Right.
only reason I know how to talk to patients in a way that creates urgency and value is because straight out of school, I worked for a DSO that sent me to training for 5 days on literally do not say cleaning if you're going to say that the patient needs SRP because they
Right.
associate the word cleaning with free.
Yes.
Just little things like that. It's like Isaac can teach you that if you need new dialogue of,
Right.
"Hey, I wanna be able to explain a root canal to my patient in as easy of a way that a two-year-old would understand it," Isaac can give you that language, or, "Isaac, please have this conversation with my patient so that they understand and answer any questions that they have so you can go see the next patient." Maybe you had a walk-in emergency patient that just came in. Now you can actually go see them and let technology help you along the way.
Yeah. Well, and a couple of things that just came to mind when you were saying that, Lauren, is number one, I have played around with LLMs, which large language models in the AI world. And, I've tinkered with like Chat GPT and Gemini and Meta and X and all these things. In all the time that I've typed things in to those, I've never once gotten a response where it says, yeah, and okay, wait a minute, I forgot what I was gonna say. We do that all the time. I mean, I do it all the time. The systems, they don't forget, number 1. And number 2, how about this, okay? Isaac, explain a root canal to my patient in layman's terms in Spanish
Yes.
or in Korean. Because that's crazy. I actually sent staff, it was one night a week for, I want to say like maybe 6 months in conversational Spanish for dentistry. I practiced in a suburb of Kansas City, and UMKC Dental School had a course that you could send folks to at night. And my whole team went. Uh, And I take that back. One of those team members is still with me. I did that because we were seeing more and more folks that came in that either didn't speak English and only spoke Spanish, or spoke very little English, but they spoke Spanish because it was their native language. And I
Right.
wanted people to at least be able to kind of communicate a little bit. But this just tosses that out the window because Isaac can speak to them in a language they can understand.
Right, and nothing is missed on top of
Right.
that, right? It's like there's so many words that are interchangeable in other languages, like in
Hmm.
I don't know what they are or, I don't have any examples, but I've
Sure.
been told where, this word can also mean this, and it's something that actually contradicts what you're saying.
Yeah.
So if we accidentally say something and then the patient receives it as something really, really serious and
Yeah.
urgent, I mean, you're talking about trust now
Hmm.
being taken and all kinds of things, right? It's like sometimes we only have one shot with the patient. And if we're not competent enough or we're not comfortable enough or anything, then it can go south pretty
Yeah.
fast.
Yeah.
So, what's your opinion on the clinicians that think tech is just for techie people or like we're going to be replaced by
Right.
AI?
Right.
As a tech evangelist, I feel like you probably have this conversation a lot. So I'm just
I
intrigued
do.
on your opinion.
I do. So one thing on the being replaced, I was at a meeting a couple of years ago, and myself and a couple of my friends, Dr. Marty Jablow and Dr. Paul Feuerstein, and I had been asked just to get up in front of a room and just take Q&A from people. And there was a hygienist in the audience, and she raised her hand, and because somebody had asked about AI, and we were talking about it a little bit, and she said, "Is this going to replace me?" And she was very serious.
Yeah.
And what I told her is, I said, "No." I said, "We don't need fewer hygienists in the profession. What we need is at least double the number of hygienists. And I think double the number of hygienists that are empowered to do as much as they can do." I'm gonna get off on a small tangent, but I won't go off the deep end.
We love tangents.
Well, I really think that dentistry needs to adopt the medical model of they've empowered different levels of nursing. And those nurses can handle things that normally it would take the doctor to do. And with the population of America increasing, with the number of nursing home residents increasing dramatically because our healthcare system is so doggone good that people live longer, but a lot of those people aren't mobile. They need to have some type of care, at least emergency care, palliative care. And we need to empower dental professionals to be able to work with all of those in indigent areas where folks don't get regular care, in areas where people are nursing home bound and they can't travel to a dental office. And so I think AI could do a lot of that help in that regard. It will let you see more patients faster, and it will help us see patients that don't normally have access to care. The other thing is that some doctors fight this because they say, number one, AI is going to take over the world. And is that a concern? I think it's a concern. I think it's a remote concern.
Right, I would agree. It's a remote concern.
I mean, we were terrified, and I'm not saying it's a good thing, but we were terrified of a nuclear war. Well, that still exists, but we've kind of figured out a way to handle it and not have missiles going off all over the place. And I think we'll figure out a way to keep this from going too far. But that's really in the big picture of, AI and society. What I would say to doctors that don't want to embrace new technologies is, one of the arguments I've heard is, well, every time you throw, and I'll just use radiography as an example, every time you throw something up there, if it's wrong and it says something's decay and it's not decay, well, then, dentists are just going to make holes because they can and because they can make money. And my response to that is, what's stopping them from doing it right now?
Exactly.
You know?
Exactly. There's overlapping on X-rays, but also
Yep.
how this is gonna sound how it sounds maybe,
Sure.
but that concerns me more about the clinician, not the
Yep.
technology.
Exactly.
I'm more concerned
Exact
of, okay, you're allowing a tool to make this decision for you, and you're relying on it so heavily that you're just
Mhm.
taking what it says blindly and seeing your patient, or, doing the
Yeah.
treatment to your patient. It's
Yeah.
like, no, this is meant to be a suggestion. It's meant to be, hey, did you see this?
Yep.
Or
Did you look really closely at this?
exactly, like maybe you should look at this again, whatever it is, or maybe seeing something so early that, our human brain or human eye can't catch it. Especially with the new AI that's coming out, right? It's just so intelligent, continuously learning. Every time you use it, it's getting better. But to me, that's not a tech error. That's a human error.
Oh, I'll say this, my friend Marty Jablow, he always says, don't check your brain at the door, which I completely agree with. And I'm actually adding on to that and saying, also don't check your soul at the door. Because that's the one thing that a machine doesn't have, is machines don't have souls. And I've also had people ask me, well, this whole thing with, crown design, for instance, well, how does it know, or how will it know exactly, like how to create certain things and all that, when we don't have any lab techs, how are we going to do that? And my response is, I don't think that by any means, any kind of AI is going to put the lab business out of business either. There's a certain, and I call it soul, but whatever it is, there's a certain something about art and like shade matching and stuff that the human eye comprehends, and I don't know that machines ever really will. And so, on complicated cases, on really difficult aesthetic cases, on the old nightmare case of dentists, which is trying to match a single anterior tooth and a high smile line, or a couple of anterior teeth, and the others don't need to be treated, I think that's always going to require the human eye. The thing that I think people need to realize is that, to me, artificial intelligence is a tool, and it's no different in the way I use it than an explorer or a perio probe.
Right.
Perio probe doesn't tell you the patient has periodontal disease. What it tells you is, here's the depth of the periodontal pocket. Is there separation? Is there bleeding? What's the color? What's the home care situation like? All those kinds of things that you as the human being factor in, that's data. AI just provides more data. but it is just data. The other part about that is, as a hygienist, some people, you can do an incredible job cleaning someone's teeth. And there are some people that will come back in 6 months and you barely have to work. And there are some people that come back in 3 months and you're chiseling a wall of calculus off. Some people build quick, some people build slow. Some people predominantly break down fast, some don't. A caries standpoint, break down quickly, some don't. And I always tell the patients, the longer I see you as your doctor and the more I see of you and your situations, the better I get at it because I've got more data. And that all of that data helps me understand, do I need to treat this? Do I need to monitor it? All of that stuff. And one other thing on this I want to bring up too, since we're talking about people might be too aggressive. The same time with remineralization therapy and things like Curodont and an Icon, in using those, you can actually monitor your therapies better because we can't see all the shades of gray on a bite wing or a PA
Right.
that AI sees. So you can actually do a better job monitoring your conservative remineralization treatment by utilizing AI than you could be with your own eyes. Yeah,
And like you said earlier, what other variables are playing into
right.
your environment, your mind, your mood, or how aggressive you are or not aggressive you are that day? What is the patient influencing you to do, right? If the
Right.
patient is super combative or if the patient is super rude or, mean to you, it's I don't care who you are, it's going to affect the way you're treating the patient, right?
Absolutely. Yeah,
And I feel like a way to mitigate that is to bring in technology that doesn't have those biases, doesn't have those variables to think about. It's just, this is what you need, period.
absolutely. Yeah,
Right?
completely agree with that.
But, well, we're going to wrap up here, but I love talking to you. I could talk to you all day, and we need to do more episodes like this, I think, together, maybe a series. I think we could talk about technology together for hours. But I want to ask you one more thing that I've been asking people, which is if you could give a piece of advice to every dental professional that is hesitant about
Mhm.
embracing new technology like an LLM PMS that we're creating, what would it be?
I would say that technology allows us to do things better and it allows us to do things faster, and you have to know how to use it. It's the world we live in. If you had a business in the 1400s of, like I communicate with the village over the mountain via smoke signals, you wouldn't have a business today
Yeah.
because people can just pick up that little black box that they carry on with them. They can communicate with anyone. And I read an article a while back that somebody said they estimate that the amount of knowledge that a peasant got in the Middle Ages in their lifetime would be roughly equivalent to one edition of the New York Times. The knowledge base is growing so fast. Medical knowledge and dental knowledge doubles every 18 months. And
That's
there's no way a
insane.
human being can keep track of that. Isaac, technology can keep track of that. You
Yeah.
have to embrace this. You have to use it. You don't have to jump in and just jump off the cliff and go into the ocean. You can, like to say, stick your toe in the water, but you've got to explore it because this is the future. And in the early 1900s, the old expression was get a horse. When somebody would be, riding down the path and there'd be a car pulled over on the side smoking and oh, those things are never going to catch on. Or if man were meant to fly, he'd have wings. But the people that felt that way and the people that failed to embrace it, they got passed by. And I don't want any of my colleagues to ever get passed by.
Right.
It's all about your patients. At the end of the day, I don't care if you are the CEO of the largest dental company on the planet. The person that pays your salary is the patient. And it's all about facilitating that trust relationship. It's all about doing your absolute best, giving them the absolute best, and embracing technology helps you achieve that.
The more we lean into it and see that it's not a threat if we how do I word this? It's not a threat if we embrace it, but also if we stay in control of it.
Yes.
I think we're more at risk if we just kind of throw our hands up and say, no, I'm not going to get involved until I have to, or something like that. Then, yes, I could see how this could be a huge problem because we've completely removed any type of control guidance that we could offer along the way as we're going to find, okay, there's a kink in this, or that's not right, or, it's too aggressive, or whatever it is. We need to be able to and give that feedback. So I couldn't agree with you more. And I think that with people like us having conversations like these, hopefully it helps our profession to understand that this can absolutely help us evolve. It's not going to keep us stagnant. It's not going to replace us, not in our lifetime, I don't think. So I couldn't agree with you more, but I'm so glad that we had you today and I can't wait to talk to you again. But thank you for being on Voices of Dental AI.
You're so welcome, Lauren. Thank you. I'd love to come back. So if you want to do a series or something, you let me know. We'll make it happen.
Sounds good.
All
Thank
right.
you.
Thank you.
Bye.
Bye.